Welcome to today's Visante Innovators podcast. I'm your host, Visante CEO Jim Jorgenson. One of the continuing themes in U.S. healthcare is really the movement of site of care from the more traditional acute care setting to a variety of ambulatory settings. And one of the fastest growing elements of this transition is the infusion services market. And today, we're going to be speaking with two innovators and subject matter experts in the infusion services space, Chris White and Erick Siegenthaler. So Chris and Erick, welcome to the show. It's a pleasure to have you with us.
Thank you.
Thank you.
So let's start with your background. Can you tell our audience a little bit about yourself and how you gravitated to the infusion market? So let's go Chris first and then Erick.
Yes, thank you, Jim. So Chris White, System Director of Home Infusion Services here at University of Maryland. I'm a little bit back myself a little bit. I'm originally from Pittsburgh, Pennsylvania. So go Steelers, Pirates, Penguins, but personal professional careers kind of taking myself to different parts of the country, from Texas, California, Oregon, and then now over here in Baltimore. I've been attracted to the infusion industry, or this maybe ambulatory side of healthcare, since my pharmacy administration days, where it was recognized that that's just a tremendous area of growth and a unique it's just a unique opportunity for pharmacists to be really embedded within the patient care, a lot of direct patient care aspects, and a smaller healthcare team kind of gives us a more prominent role. And again, with that growth opportunity, always areas for expansion and new frontiers here. And not to get into the weeds yet, but this is where healthcare is moving to, the last frontiers of the home. So thank you.
Awesome. Yeah, thanks for joining us, Chris, and thanks, Jim. For me personally, I had the opportunity to actually, back in pharmacy school, I was, more interested in retail pharmacy, coming from a small town, and had the chance to meet Visante managing partners, Phil Brumman and Steve Rao, when I was in pharmacy school, and really was kind of enamored by the growth of pharmacy, specifically health system pharmacy. And at that point, it was, how can we get pharmacists in our ambulatory clinics and specialty pharmacy? And that was really interesting to me. Had the chance to complete an administrative pharmacy residency at Freighter Health in Milwaukee, Wisconsin with Phil Brumman. And it was there where I got exposed to home infusion. To me, it was a perfect mix of kind of retail pharmacy. I love the business of healthcare and how do we kind of solve some of these problems that we're facing, and specialty ambulatory pharmacy all packaged into one. So I had the opportunity to start up services at Freighter Health in 2017 and really just, learn as we go, because there is no right or wrong way to do infusion. So that was really fun for me to be creative and figure things out, and had the opportunity to grow that, as well as ambulatory infusion suites, and addressing some of the topics that we'll talk about today, like site of care, payer restrictions, and getting patients out of the hospital and really providing the best care we can for them. So thanks again, Jim.
Excellent. Just in terms of the overall infusion market, can you guys give us kind of a broad perspective of where you see the market currently?
Sure. I'll start on this one. I think I would say the infusion market mimics the healthcare market in general, right? We have an aging population, increasing incidence of chronic disease. So really the need for these services increase. And as we get more complex with our medication therapies, many of these molecules are become more complex and are often injectable or infused products, right? So I think it's increasing population, increasing age and incidence of disease, and as well as the type of medications all really bode well into infusion period. And as Chris alluded to earlier, I think healthcare in general looks at how do we get patients out of traditional settings like hospitals and get them to be taken care of in their home, where they want to be, where it's likely safer, generally less expensive as well. So I think, that's infusion in general. So I don't know, Chris, do you have anything to add to that?
No, I can add a couple pieces, and what you said was perfectly accurate. The infusion market's growing. The drug portfolios are growing, and these drug portfolios tend to be high cost, chronic disease state specialty market drugs. And so the traditional side of medicine, the regulated side of medicine, whatever synonym you want to use, just like you're seeing maybe earlier on with surgical procedures being shifted out, or now with infusions, but also lab. Just there's a mass push to alternate sites of care, whether that's, and that infusions not new to that either. And as these new drugs come out, it does seem that the manufacturers are being very careful with the language and the studies, to where they're indicating the safety profiles more explicitly to promote home-based use or suite-based use, just not in the traditional inpatient side. So there's some motivators for the manufacturer to choose these alternate sites of care, but also the payer is motivated as well, and the hospitals potentially trying to shift costs. So the infusion itself, future's bright. The industry as a whole, infusion is bright. So I'm just very happy to be where I'm at today in this phase of my career, because there's a lot coming at us, and it's a really fun job right now.
Yeah, and we talked a little bit at a high level about infusion, but Chris, you kind of spurred my thought on two pieces. Mm-hmm. So at Visante, we're working with clients, a variety of different models, whether it is home infusion focused around site of care challenges or opening up infusion suites. But I think, we're still seeing health systems enter into this space at a very rapid pace. So we talked about the number of infusions growing, but also I think similar to specialty pharmacy, right, where people were, let's see what happens, and now we all got to get into this. I think organizations are infusion and home infusion is in the similar phase that specialty pharmacy was. Spurred by a couple of things. To keep it short, traditional infusions that Chris alluded to, so patients leaving hospitals on things like antibiotics, TPN, hydration. 2022, the big news in the infusion world was some of the national infusion providers leaving the local markets. Not that these services are not profitable, but I think when you have a national company, you need to have people on the ground at the sites to develop those relationships to essentially sales, right? And liaisons in those locations. So that wasn't a model that could be reproduced. So we see organizations leaving, which actually leaves hospitals in a tough point, because these are your most sick patients in many ways, right? Like they're sick enough to need an IV. And so those patients without a provider that can support them are stuck in the hospital. So that's a challenge. And organizations, we're hearing that from them. And then I know we'll talk a lot about specialty infusion and site of care. We continue to see that grow. I was just looking at some data the other day. One national payer, for example, 2017, when I opened home infusion at Freighter, for example, this payer had one drug on their site of care list. And in 2022, they had over 130. So 5 years and continuing to grow that list and looking at ways to reduce costs. And so I think, organizations have to be nimble, as well as look at the pharmacy department, right? And how can you support some of these services? And again, hearkening back to specialty pharmacy expansion. And I think that's a good model that home infusion follows. Certainly a little bit different, but very similar idea.
Let me pick up on that expansion theme that you both mentioned. At Visante, we do have the opportunity to work internationally, and in countries like the UK, they are much more aggressive with home chemotherapy than we are. In fact, I think home chemo is one of the top infusion services offered there. So do you guys think programs like the University of Pennsylvania's home chemotherapy service are going to continue to expand and to move the US home infusion market closer to the direction taken in countries like the UK?
I think that'll be interesting. I think some of the traditional chemotherapies like 5FU have been part of the, quote unquote, old school of what home infusion was. I think there are obviously, unique challenges that are presented by providing anti-neoplastic hazardous medications that creates some cost and structure. But I think where, in the oncology world is evolving, right, to more targeted therapies. And actually what we're seeing, so medications like Keytruda or Opdivo, so some of your targeted oncology products that aren't maybe your historical anti-neoplastic, but more of your targeted monoclonal antibody products. Those drugs are high spend drugs for payers, high revenue for hospitals. And we're seeing those start to be put on payer side of care lists as well. So I do think organizations are looking at that and how that could impact their patient care, whether it's revenue or if it's fragmenting care or access to care. I think there's some opportunities there, but I think there are also some unique challenges. So I guess, long story short, yes, I think it'll mimic the move in the types of therapies that are being provided in the oncology world today. And I know University of Pennsylvania, for example, they have done some unique things and programs and coordinated really well with their clinics to help support some of these therapies.
Yeah, I'll just add on to that. I would say a more firm yes, that it will be shifted. This is going to be a reactionary. We're seeing it real time in Maryland right now, where our oncology groups are recognizing denial of data, particularly around the MABs, not the hazardous medications, but that's the first salvo from the payer attempting to shift out high dollar oncology-based medications to an alternate site of care. So whether we want to try to be proactive or not, it's still a very reactionary based system where, based on payer mandated changes, we need to accommodate. And so it's very important for us right now to get an infrastructure in place, whether that's home infusion or infusion suites or unregulated versus unregulated areas within a robust health system, in order to be able to triage these patients in a reactionary focused manner. But I would just keep it in oncology focused. Yes, I do think that we need to be ready to be able to provide oncology services outside of a traditional hospital-based infusion center, because the payers make a decision on our behalf. So heaven forbid the patient gets a choice where their care is at. Sometimes they do, sometimes they don't, but typically it's the payer driving it. And so right now in real time, the inpatient oncology leadership is engaging with home infusion services here at University of Maryland to see what we can do to help with their situation, not just within the infusion of the med itself, but also within labs, because they're finding the same challenges with labs and denials for their cancer patients too. So I think home infusion and pharmacy in general is very well positioned to help mitigate these shifts and kind of position themselves at a higher level within organizations.
Excellent. Yeah. Any other non-traditional home therapies you guys are kind of keeping an eye on?
Yeah, I think there's some really interesting movements in infusion, and again, I think that's what probably drew both Chris and I to the world, is it's ever changing. I would say a couple call outs is Alzheimer's is a big area, obviously, of focus in terms of research and treatment, and recently products like Aduhelm, which maybe never really quite hit the way it was expected to, but I think the idea that there are therapies in development, new products coming to market like Leqembi, that may be eventually be really well suited for home patients, right? I think with that population, there will be a question of is it a Medicare population or is it a commercially insured population, and coverage of some of these therapies for Medicare patients, there's work to be done. They're not well covered in the home setting. So I would say that's one. We talked about oncology, targeted oncology therapies, biologics. And, I think there's a really, new drugs that come to market really focus on a smaller set of patients, and looking at those, they're often complex molecules that require infusion or injection. So.
Yeah, and on top of those two buckets, I would add gene therapies as well coming to the mix. So in Maryland, we have a really unique payer model here. It's one of a kind in the nation, where in simple terms, it's basically a capitated approach for the regulated hospital settings, where their revenues and expenses are fixed and set by a rate setting commission in order to control healthcare costs. And on a broad scale, population health level, it does lead to lower patient level per patient care amounts, expenditures on the state level government. With that, when it does come to these high cost gene therapies, let's say Luxturna or Zolgensma, those are $500K to over $2 million respectively just to purchase. These are curable, life-changing medications, and yet in this setting, we can't afford to do them. It would be a budget breaker in these hospitals, but perhaps leveraging home infusion or nearby infusion suites that are strategically located within the medical center's reach, that we could actually start servicing these medications as well. But again, having a robust infrastructure to be able to triage certain patients, either based on cost or choice or safety profiles. You need to have, in simple terms, all three sites kind of covered, from your spectrum of the regulated setting, hospital-based infusion, to the home, and then that sweet spot middle ground, infusion suites and strategic areas throughout your geography.
Both you guys touched on some of the key drivers behind the infusion market expansion. And obviously one of them that continues to get a lot of press is site neutral payments and site of care. Could you guys maybe both expand on that a little bit more?
Sure. We're working with many organizations, I think, on how do you address this. So site of care requirements. So in short, payer mandate for patients to receive medications in a lower cost setting, right? So for infusions, moving them out of hospital-based clinics into physician office, home infusion, or freestanding infusion suites. I talked about the growing number of drugs that are on those lists, and really the goal is to reduce expenditure, right, for the health plan and for the employer that's purchasing the plan. This is frankly, it's a threat to health systems, right? Because I think medication reimbursement for some of these specialty products is very profitable or high revenue, and helps to support many of the services that are provided in other parts of the organization. So we see this as a challenge, but we think of home infusion and in infusion suites as part of maybe a pharmacy-based infusion suite. And other models is, I try to think about it as, you need a continuum, right? Like, we need all levels of care, and there is a right place for patients. And home infusion really fills a gap for that, as well as pharmacy-based infusion suites. So I think a challenge, but really an opportunity. And we're being brought in because we're hearing more of site of care, but I think what we're finding out anyways is that organizations are already losing a lot of this business to other infusion providers, whether they can see it or not, based on some of the ways that the medications are ordered. So it really it highlights the challenges that are already there. And again, solution, home infusion and pharmacy. So.
Yeah, I echo everything Erick just said, so nothing additional to add.
Yeah, Chris, you're doing something pretty unique at Maryland with repurposing some of the COVID facilities. Can you tell us more about that?
No, absolutely. So in Baltimore, for the COVID response program, they had a really unique collaboration between the Maryland Department of Health, University of Maryland Medical System, and Johns Hopkins Medical System as well, where and there's a couple other affiliates. This is before my time over here, but essentially they worked with the National Guard, Maryland Department of Health, to create these MCUs, which stand for modular care units, where from the outside they unassumingly look like a couple trailers attached together, but on the inside, these are Army grade field hospitals. If you're on the interior, you would think you're on an inpatient hospital medical wing on the 8th floor. But despite that being just a first ground level building. And these we'll call them trailers for now, but these modular care units, they were doing remdesivir infusions during COVID. And we were in collaboration to try to be the first home infusion institution to do home-based remdesivirs and somehow triage these patients based on their first infusion. We'll pick up the next 2 infusions. Ultimately, the timing didn't work out, where the pandemic was subsiding, and then the revenues, not revenues, but the government support was subsiding as well. And then the program just kind of collapsed. And during the COVID unwind, the trailers still remained, and they were set for demolition. But seeing there's an opportunity, because the location is right across from our major flagship medical center, it's also across from the specialty clinics. Instead of completely demobilizing and demolishing in the field hospital, why don't we repurpose that into a hybrid between infusion suite and infusion center? So it's 16 private patient rooms. We're going to try to occupy half of it, and we're going to actually launch our soft opening next week. But this offers a very, I think, robust. It's more than an infusion suite. It's more than putting 3 to 4 patients in a room together with curtains. These private patient room approach could offer us a more advanced approach to these infusion suites, whereby having some negative pressure rooms, that's what they're built for. We did want to go back to COVID era kind of precautions, we could offer maybe some more hazardous-based medications more safely next to each other because they won't be crammed in the same spot. But also from a patient satisfaction standpoint, them having their own private room with a more advanced kind of setting, they might feel more comfortable there. And maybe we would try to, if there's some questionable safety profile patients, insist on them being in this suite setting versus the home setting. So I call it a suite. It feels like an infusion center, but I think that's the kind of the next step is you got to get more and more nuanced to the sites that you offer patients. And it's not just based on the dollar or patient choice, but it's also the safety profile and some convenience aspects too. But this is going to be a really big win for a health system for us to utilize a resource that was essential during COVID and to maintain its readiness in case if COVID did return, this field hospital could be repurposed right back to its original COVID era versus just demolishing it and then having to scramble again. So it's a good collaboration that we're still maintaining with Maryland Department of Health and with the medical center.
Wow. Well, we'll be interested to see how that works out. Exciting. So, what are you guys seeing as some of the biggest challenges for hospitals that are interested in getting into the infusion market or expanding their infusion profile?
Sure. I think that can be different, right, for every organization, but we talked about home infusion not necessarily fitting inside of a box. I think there's not a clear path, right? Like setting up a retail pharmacy for a pharmacy department is very clear. You need a license, you need a space, you need to follow the Board of Pharmacy rules, you need to get pharmacy contracts, et cetera, et cetera, et cetera, right? Accreditation. I think home infusion is not as clear. We're looking at payer contracting on medical benefit plus pharmacy benefit. We need clean room space. We may need nursing staff. We're not, when I was at Freighted, I had more nurses that reported to me than I did pharmacists. So I jokingly said that I was actually a nurse manager masquerading as a pharmacist. So I think it's hard, and historically, pharmacy's role in infusion and within a health system maybe is related to drug preparation and maybe billing, prior authorization, but it's not really kind of running the whole show. And there's providers that are part of this. There are usually like a nurse clinic leader that's part of it, and how that rolls up traditionally there's many stakeholders. So when we look at home infusion, it's not just pharmacy opening a retail pharmacy. It's pharmacy. It could feel like you're trying to take a piece of the pie. We're not. And there are many stakeholders that you need to take into consideration as part of that. So I think that's a challenge. But I think what we really try to do is come in and bring together the sides and really paint a clear picture of like, here's the challenge, right? Like there are challenges and here's the opportunity. We are not we're not in the business of trying to compete with a hospital-based infusion clinic. We look at it again as like a continuum of care. There are patients that need hospital level based infusion care. There are patients, if I were to get an infusion, personally, I would love to be working at home and getting my infusion. Right now, if you didn't know, I could have a peripheral IV in and I could be getting my IVIG infusion. So I think there is a change in where people want to receive care, but I think there's a need to have all sorts of levels of care. We look at, what are you losing today? So you are likely, and we worked with Chris on this, is, hey, these are your infusion competitors. Your providers are sending these orders to external providers, not because they mean poorly. It's because they need to support care for their patients and they're having to figure out a way. So how can we incorporate into workflows to help support and take workload off of providers? I think, the other thing is maybe cost, right? We talked about clean room and USP 797. That can be a barrier to entry. We look at, are there ways that you can synergize with current services, whether it's an inpatient pharmacy, or if, maybe you start out just providing specialty products that don't require, significant compounding. So we talk about infusion suites, that we do have some partners that are really starting in the specialty infusion suite world because site of care is their biggest challenge, hoping to show proof of concept. And maybe there's a point in the future where they're going to open up a centralized service center or can work to compound more complex pharmaceutical compounding. So I would say those are probably the two main barriers is cost of entry, clean room specifically, and then the complexity of the stakeholders.
Excellent points. I want to touch on go deeper on a couple of them. So I think the biggest messaging that we have to get by a lot of times is, I use the term cannibalization. We're not trying to take left hand from right hand and hurt anyone else's P&L within our own health system. We're attacking what's currently leaking, and the leakage in any health system is substantial. And then once we finish up with our own leakage, then we can start creating a very sophisticated site of care algorithm. So based on that patient insurance or choice or safety profile, then we can start determining, well, it's actually, you have bad volumes in your infusion center, and that should go to the suite. Or you have bad volumes in the home, that should go to the suite, or vice versa. So I think the messaging, that's when I do my road shows to the 12 different hospitals that we try to support, I always start off with that, just to clear the air about we're not taking business. If anything, we're a 340B contract pharmacy with most of you. So our existence does provide you some quality, but also financial outcomes as well. And then I would not undermine or underestimate the business side of home infusion. It might just sound like just a pharmacy service line, because it's traditionally a pharmacy service line. It's just one piece of many types of pharmacy. But as Erick alluded to, this in his intro, this is the sweet spot, in my opinion, of pharmacy. It's all elements of pharmacy, but it's also its own independent business. So it feels like I'm sure Erick felt the same way, but you feel like a miniature CEO when you're running this operation, because it's your own rent, it's your own payer contracts, it's your own supply chain. It's not just pharmacists, like he said. We have nurses, we have social workers, we have dietitians, we have at one point a business development manager before my time. But it's a very diverse service line with diverse needs. And depending on where your location's at, you might not be affiliated with a hospital, and which means, well, you're always affiliated, but you might not be tucked under the umbrella of a hospital. So environmental services, that's on you to figure out. Facilities, that's on you to figure out. And IT needs, typically that could be supported. But there's a lot of moving pieces to home infusion. And I think the barrier to entry creates a lot of stakeholders, like Erick said, but also the leadership needs to be pretty well-rounded and have a good support team to be resourceful, because you kind of are on an island. At the same time, you have, like I said, all those moving pieces. So I'll stop there. But I think, again, I could not be happier with where we're at, what we're doing, because of all the different things that we get to do and touch each day in this very evolving landscape.
Yeah, and since you guys are working very successfully together on the Maryland Infusion project, for other organizations interested in getting into this or expanding, how did you guys just approach that support in general?
Sure. So at Visante, on our infusion strategy and optimization team, today we're talking about home infusion and site of care infusion suites. But really, at Visante, we work anywhere where medication is, and I think on our team we work on any part of where infusion is, right? So I think the way I describe the type of work that we do and how we partner with clients is many ways. We've got assessment type work. Hey, we have this problem, whether it's site of care, or hey, we want to figure out how to increase bandwidth in our infusion clinics, or we may be interested in opening up a home infusion service. We come in and we assess and help to build a business plan and pro forma, help to lay out what's this roadmap look like, and start to socialize it amongst those many stakeholders. So that's a common way to enter with us into that. We usually find many opportunities that aren't just related to the specific scope of work, but infusion touches things. Chris said 340B. We talked about denial, so revenue cycle management. We've got a team that we bring in that takes a look at that to see, are there denials in your infusion clinics that shouldn't be? We look at medication access, so prior authorization. Are there ways to improve that to reduce some of the denials, or to increase access, or to track site of care denials? We also, work from a pharma IT standpoint to say, home infusion, for example, traditionally can't really use your EHR records, your Epics, your Cerners, for example. and has all been held outside of that. But how can you maybe leverage specific tools within those programs to improve transparency, communication, ease of accessing your own services? So we're really looking at those sort of ways to improve services as well. We do work with organizations to stand up infusion. So I again defer back to home infusion, which is common, but we have partners that we're helping to support building infusion suites. So hey, we're getting site of care denials and we need a solution to help support that, whether it's a provider-based suite or a pharmacy-based suite. We do that. And whether they're partnering with an outside vendor or they want to do it alone, we're really agnostic in that approach. And then really the way we're working with Chris is helping to grow the business. So Chris and I meet, I don't know, at least 2 times a week, if not more. And really we are strategizing on ways to improve care, improve revenue, overcome barriers and challenges, and help to socialize what is Chris doing. We talked a lot about that, and how do you help people understand that we're not competing, we're growing access, we're helping to improve the business of the health system. And so we call that like optimization type work. And then throw in with Chris as this partnership expands is helping to set up the infusion suite at the MCU, and I think we've got a tall task ahead of us to open up another 2 probably over the next 12 months. And again, really excited about that and have appreciated the relationship. So,
no, I appreciate the relationship as well. And I wasn't originally a part of the initial justification, but at the end of the day, you just have to identify the value system of your stakeholders and justify an ROI for our next step. So we took over kind of a limping along service line that's been around for about 5 years and just identified the areas of opportunity and growth. And for us, it's within both buckets, traditional medications and specialty. So using leveraging Visante's insights, but their ability to acquire maybe some payer level data for us to assess leakage from the different various hospitals, but particularly our specialty suites, or not specialty suites, sorry, particularly from our specialty clinics where the leakage is occurring. And then identifying the key clinic leadership stakeholders, positioning our liaisons appropriately within those clinics, and then identifying that we can't handle this all just in the home base because there are set of care issues and patients want facilities where the clinics would prefer us to have a facility. So just justify the amount of leakage associated with not having a facility because it's going elsewhere, pays for itself relatively quickly. And then it's comparing that to patient geography, recognize that we need more than 1, possibly 4 or 5 or 6 throughout this complex state of Maryland. And then beyond that, how do we generate additional value? It's not always just about dollar, it's within Epic too. So yes, there's no out of the box Epic-based home infusion module. It could be coming around the corner, you always hear, but at the end of the day, there's a lot of functionality within Epic that we could be leveraging today that maybe pharmacy has not advocated for in the past, and now we are. So there's work queues, there's smart sets, therapy plans, there's MyChart communications, there's nursing Mars, all that stuff. The customer, the patient appreciates it. Also, the referral source, the clinical team, they want it as well. So the value propositions extend beyond simply dollars and cents. The more that you ask for and the more you provide justification that you need it or deserve it, we're making moves here. And it's, again, thanks to Visante and the, I guess, all-encompassing approach that we're taking to this home infusion line. It's not just home-based care. It's not just specialty traditional. We're doing a lot more.
Definitely.
You both mentioned continued release of more high-cost specialty meds that are infused. How do you see a hospital's infusion program interacting with their specialty pharmacy services?
Yeah, that's a great question, Jim. I think one is these medications. You talked about more medications coming out that are infused. Well, some of the infused products are going to be injectable medications in the future, and injectables are going to be oral medications, right? So there are some unique operational and financial, frankly, needs of home infusion providers. But your organization has specialty pharmacies, right? Like specialty pharmacy was first to market, home infusion is following. I think there's a lot of patients that go back and forth between, right? Like I might get Humira today, stops working, I need infliximab tomorrow. So that's a specialty patient and a home infusion patient. And then, oh yeah, I have my immune system is reduced, so I happen to get an infection. So I also need an antibiotic. So really, these patients touch all parts of your pharmacy. So I think figuring out how you can synergize is important. And actually, with Chris, we're trying to figure that out as well. How do you work together if there's a patient that specialty pharmacy can't service? Could home infusion service it? Or vice versa, right? Like we want to keep care for the patient within the system where we feel that it can be best provided. So it could be things like also CSC, Centralized Service Center, looking to develop a justification to open up a facility where you can create some of those synergies or economies of scale. Those business plans work really well together. And some of the services, if you can figure it out, some of the services are very similar. Chris's team is following up with patients receiving infusions, doing clinical assessment, documenting it, and dispensing drug. That's exactly what a specialty pharmacy does. He's also got accreditation, and his specialty pharmacy at Maryland also has accreditation, right? So we think these have often been stood up separately, but how do we bring them together if they're already existing, or as you implement some of the services, are there ways that you want to consider pulling them in together? So I think there's a lot of opportunity there for organizations, whether they're in an early phase or in a late phase.
No, I 100% agree with everything you said. I have a couple drug level details that we're working through right now as we become better partners between my silo and the specialty pharmacy silo. That could be Stelara and Skyrizi. A lot of these medications now, they're coming out with first one you have to get infused, maybe the first 2 or 3 you get infused, and the remaining ones are sub-Q. So who handles that? Should we clear bag all of it from specialty pharmacy and infuse it, and then they own the sub-Q aspect thereafter? Or should we try to own the infusion, buy and bill ourselves, maybe still continue the sub-Q therapies ourselves, or transfer them to specialty pharmacy? So there's some interesting therapies that seems to be a theme where they're coming out with that type of model. And we have some standing meetings that we're starting to work through what would be our preferred algorithm. So that way, when these pop up, it's not always kind of a all hands on deck, let's think this through approach, or I can't help, or vice versa. So the medication itself is driving partnership. And then, yeah, I'm very excited. We're right now engaged with Visante to develop our own logistics center, centralized services center. And it's maddening that these groups aren't already in the same building, because I have big refrigerators with high cost medications. You do too. I have mail order cold chain custody. You do too. I am Joint Commission accredited, and you're URAC. I can do URAC or vice versa. We have specialty pharmacists. You have specialty pharmacists. There's so many opportunities for us to lean the operation out and to merge forces. And they're specialty pharmacists. They're already doing a lot of documentation that I have a lot of ideas, and I'm really excited to start sharing a building with them, because there's ways for us to offload some of our work, and there's ways for us to take some of the work from them. And it's just going to be really good for us to join forces, just from a operational synergy perspective, but also from a clinical care coordination perspective as well.
I also want to give a little bit of a shout to our medication access services or prior authorization patient assistance, because we're trying to encourage organizations to, pharmacy is really well positioned to be able to help triage those needs, do the work, and then also figure out where's the right place for that patient. So Chris talked about an algorithm and what's the right set of care for a patient, or what's the right position. Specialty pharmacy, infusion, medication access, hospital infusion, those kind of all go together. And I would say that's another area to create some synergies with as well.
Yeah, maybe one more area too. I'd love to get your opinion on, another ambulatory concept that's getting a lot of interest is the whole idea of hospital at home. So how do you guys see infusion services interfacing with the development of these programs?
Yeah. I think it'll be interesting to see how that evolves, right? Home infusion providers are set up really well to I would say many home infusion providers would consider themselves hospital at home providers, technically, right? They aren't, but they are. We compound medications and provide services to patients in their home, and send nurses and take care of the patient and help them recuperate. And so it's really cool to see the advancement of hospital at home. I think, Chris said it earlier, where, all care is moving out of hospitals and closer to the home setting, and literally hospital at home. It couldn't be more literal of that. Home infusion providers are already doing some of this. So it's figuring out maybe some of the more operational aspects of how do what about oral medications versus IV medications? How do you bill? How do you document? So bringing together some of those technologies, like we talked about, using your EHR, your hospital's EHR system versus your home infusion system can be tricky. But I do see that as a very natural progression, to support some of that workflow. So definitely opportunities there.
Yeah, it's an interesting concept, and there's nothing much in the literature still on hospital home models. There's just a few pockets that's producing outcomes right now, and I think it's going to be interesting how it shakes out. So from a pharmacy enterprise perspective, obviously pharmacy has to be involved, but as far as who owns what will be interesting. So home infusion, home-based care, operations, getting the medication to the patient, logistics, we have that mastered. The billing, the lack of access to maybe the primary electronic health record, maybe that around the clock clinical ICU intensivist acute type of pharmacy clinical supports. That's not quite our scope. So we need inpatients involvement somehow, and whether that's going to be us teaching them how to operationalize this themselves, or how do we leverage their clinical pharmacists, and then we maintain the operations. There's so many opportunities how this could be shaking out. But I would be concerned with the billing components, with a lot of this hospital home model being driven by CMS, and us still being carved out within home infusion for Medicare reimbursements or benefits. So yeah, it's an evolving piece of pharmacy, and I'm glad to see that. I think that the health systems who are approaching it, they know that pharmacy is a part of it, and it's a good feather in the hat for pharmacy to try to own and operate.
Well, tremendous insights, guys, and I really appreciate your thoughts. If anyone has questions and they'd like to reach out to you, how do they contact you?
Yeah. So from a Visante standpoint, so I can be reached via email. So my and then my last name, Siegenthaler, at visanteinc.com, or certainly through our website, through the contact us functionality. We get those and we turn them around pretty quickly. And always happy to talk about what you're seeing locally, and kind of just back and forth. I'm passionate about infusion, period, right? Like whether or not we are going to partner, my goal is to help support the growth of infusion services, and I love it. Again, it's outside of the box. You have to get really creative, so there's lots of options. So, Chris?
Yeah, I can be reached via email as well. Christopher.white@umm.edu. That UMM stands for University of Maryland Medical. And then not much of a social media guy, but I do have a LinkedIn, so you can find me there. And I'm also pretty involved in ASHP and Visante as well. So always looking forward to collaborating. Just talk shop. I love pharmacy. I like where the industry is going, especially ambulatory care. So not just home infusion, but specialty medications and things of that nature. And just always happy to listen and help and collaborate.
Well, thanks again for joining us on the show. And thanks to everyone listening for spending some time with us on this podcast.
Awesome. Thanks, Jim. Thanks, Chris.
Yeah. Thanks, Eric.
Great.